Dear course participants, all malaria programs at national or subnational level need to be oriented to the activities and dynamic strategy required to interrupt transmission, to prevent re-establishment, and to achieve WHO certification. This malaria elimination training curriculum aims to equip participants with the knowledge and skills to plan, implement, monitor and evaluate a program for malaria elimination and prevention of re-establishment of transmission. The course will cover all relevant technical areas, included but not limited to malaria parasite biology, immunology and epidemiology, surveillance and response, case management, vector control and entomological surveillance, acceleration strategies, stratification to tailor interventions, and management and planning of an elimination program. I wish you a very pleasant learning experience. A confirmation of participation is available to participants who completed 100% of the course material. Dear core participants, good luck to all, and let's get started now.
Dear participants, this unit covers the rationale for malaria elimination. By the end of this unit, you should be able to describe how the geographical distribution and burden of malaria have changed over time, explain how your country will benefit from the elimination of malaria, and describe what may happen if countries come close but fail to fully achieve elimination. Over the last 100 years, there have been significant changes in the global burden of malaria. The map on the left shows the extent of malaria transmission around the beginning of the 20th century. At that time, the range of malaria extended up into Northern Europe and North America, almost into Canada, and as far south as the northern reaches of Australia. The two maps on the right indicate the 2017 distribution of Plasmodium falciparum on the top and Plasmodium vivax on the bottom. By 2017, the extent of global malaria transmission has shrunk considerably, with Europe, North America and Australia now malaria-free. This significant progress, due to increasing coverage of effective malaria interventions and socio-economic development, has led to increased recognition of the potential to eliminate malaria for many countries of the world. We will briefly review some key research findings that have contributed to the fight against malaria. The malaria parasite was identified in 1880 by Laveran in Algeria. In 1897 in India, Ronald Ross worked out that the parasite was transmitted by Anopheles mosquitoes. Understanding the role of mosquitoes in the transmission of malaria led to the development of techniques that helped some countries in Europe to eliminate malaria before the Second World War and greatly reduce the burden of malaria in Europe and the United States of America. Chloroquine was discovered in 1934 and was eventually used to prevent and treat malaria. The insecticidal properties of DDT were discovered in 1939. In the 1940s and early 1950s, the adoption of indoor residual spraying with DDT and soon after with other long-acting insecticides led to spectacular successes in controlling malaria in the parts of South Africa, the Americas, India, Southern Europe and the former Soviet Union. It is also during that time that primaquine was used in 1946 to treat and prevent malaria stages that persist in the liver. Artemisinin was discovered in China in 1972. The discovery of artemisinin dramatically changed the landscape to combat malaria. There was a shift away from quinine-based antimalarial drugs to artemisinin combination therapies due to the emergence of parasite resistance to quinoline drugs, that is quinine, chloroquine, primaquine and amodiaquine. In 1985, the first trials were undertaken in the rural areas of Gambia to investigate the impact of permethrin-treated bed nets on malaria. By early 2000s, insecticide-treated mosquito nets had become the cornerstone of malaria control around the world. Since April 2001, WHO has recommended the use of artemisinin-based combination therapies for treating malaria, and these medications are being used worldwide. In the earlier slide, we saw how research findings have guided the strategies and policies for malaria control and elimination at different points in time. In this slide, we will review several key milestones in the fight against malaria. In 1955, with the endorsement of the World Health Assembly, WHO launched the Global Malaria Eradication Program as its second eradication initiative after smallpox. During this period, Grenada became the first country in 1962 to be certified as malaria-free. After termination of the Global Malaria Eradication Program in 1969, WHO recommended that national governments evaluate their programs to determine whether they could achieve eradication in the short term or whether they should be considered as control programs. The launch of the Rollback Malaria Initiative in 1998 and the establishment of the Rollback Malaria Program in 1998 by WHO, UNICEF, UNDP and the World Bank attracted greater financial investment in malaria control. The year 2000 saw the Abuja Declaration, where 189 heads of state adopted the Millennium Declaration designed to improve social and economic conditions in the world's poorest countries by 2015. In 2002, the Global Fund to Fight AIDS, Tuberculosis and Malaria was established in Geneva as an international financing organization, a public-private partnership aiming to attract, leverage and invest additional resources to end the epidemics of HIV/AIDS, tuberculosis and malaria, to support attainment of the Sustainable Development Goals established by the United Nations. 3 years later, the President's Malaria Initiative was launched as a United States government initiative to control and eliminate malaria, one of the leading global causes of premature death and disability. In the same year, there was the Tashkent Declaration, a commitment to action signed by the Ministers of Health of 10 countries in Europe. In April 2016, WHO declared that the European region had achieved an important milestone. All 53 countries in the region reported zero indigenous malaria transmission for at least 1 year. The Tashkent Declaration was instrumental to this achievement. The Global Technical Strategy for Malaria 2016-2030 was adopted by the World Health Assembly in 2015. We will learn more about this strategy in the Unit 1. This is an overview of the 40 countries and territories certified by WHO as malaria-free. After the start of the Global Malaria Eradication Program, and until almost 20 years after it ended in 1969, 27 countries and 1 overseas territory eliminated malaria and received WHO certification. However, in the subsequent 2 decades covering 1988 through 2006, no country was certified by WHO, although many continued their efforts to achieve malaria elimination. The drought was broken in 2007 when the United Arab Emirates was certified, with 12 more countries certified to date. In 2021, one of the smallest countries in the world, El Salvador, and the most populated China were certified as malaria-free. The certification of these 40 countries and territories was hard-won and represent a significant public health achievement. Although each country had a specific set of challenges to overcome, all countries that have been certified as malaria-free share the common vision, strong leadership, and commitment to ridding their country of diseases that kill their citizens and depress their economies. Between 2000 and 2015, remarkable and unprecedented improvements in the malaria situation were seen globally. At that time, the World Malaria Report 2016 estimated a 37% decrease in the incidence of malaria cases and 60% drop in the malaria mortality rate compared to 2000 levels. While the incidence and mortality rate estimates have been revised somewhat since 2016 World Malaria Report, the declines during this period remain evident. General improvements in development and other social and health interventions probably also contributed to these decreases, but statistical analysis do show that malaria interventions, particularly vector control, played an important role in creating substantial declines. Since 2015, progress has not continued, and currently the world is off track to meet the 2030 reductions in mortality and diseases due to malaria. In addition to the reduction in malaria burden described in the previous slide, a growing number of countries are approaching malaria elimination. This graph shows the cumulative number of countries that have reached very low levels of malaria case numbers over the period from 2010 to 2020. The baseline for these graphs is the number of countries that were endemic for malaria in 2000. The yellow line represents the number of countries with fewer than 10,000 cases. We use this number to arbitrarily indicate countries approaching elimination. This number has increased from 39 countries in 2010 to 47 countries in 2020. The number of countries that reported fewer than 100 cases is shown in orange. This number rose to 26 in 2020. The blue line shows that there were 23 countries with fewer than 10 cases in 2020. This graph shows steady and important improvement in the number of countries approaching elimination over time. These countries still have a long way to go, but we think that they can probably achieve malaria-free status in the next 10 to 15 years. Therefore, it is no coincidence that in 2015, right when we were really starting to recognize the benefits of scaling up our malaria interventions, WHO published the new Global Technical Strategy for Malaria 2016-2030. Many countries around the world are approaching elimination. Pictured in this map are 21 countries chosen by WHO to take part in a special effort called the Elimination 2020 Initiative to share lessons learned and accelerate progress towards elimination. WHO is working very closely with these countries, monitoring their case numbers and providing a range of technical assistance to help improve their program performance and efficiency. In 2018, Paraguay and Uzbekistan were awarded WHO certification of malaria elimination. In early 2019, Algeria and Argentina achieved certification, and in 2021, both China and El Salvador were certified as malaria-free. In 2021, WHO launched a follow-up initiative called the Elimination 2025. There are 25 countries and one overseas territory included in this initiative that is working to achieve the 2025 elimination milestones of the Global Technical Strategy for Malaria 2016-2030. Why should we eliminate malaria? There are many important diseases in the world. Why malaria? We could say there are four main reasons which we will explore in the following slides: public health improvement, economic development, equity, and prevention of resurgences. Let's discuss each of the major reasons to eliminate malaria in more depth. Malaria is responsible for more than 241 million infections annually. It is one of the most important causes of death worldwide, with more than 627,000 deaths a year. Most of these infections and deaths occur in sub-Saharan Africa. The age group most affected are children under 5 years of age. Globally, malaria is responsible for 7.8% of deaths in children less than 5 years old. In malaria-endemic countries, malaria may be responsible for a large proportion of outpatient visits and inpatient hospital admissions. The burden to the health system resulting from malaria can be extreme. As a result, the treatment of and response to other diseases may not have the resources they need because of the significant malaria burden. Malaria causes illnesses and deaths directly, but it also causes serious indirect effects that are not necessarily well appreciated. Malaria in pregnancy affects the fetus by causing intrauterine growth restriction and preterm births, which in turn are strong predictors of infant mortality and morbidity. Malaria causes anemia, where hemoglobin level in the blood drops below 11 grams per deciliter. Severe anemia, defined as hemoglobin level in the blood less than 5 grams per deciliter, is associated with increased risk of death, while even mild to moderate anemia may impair cognitive and motor development, growth, and immune function. There have been several studies showing that in areas highly affected by malaria, school attendance is negatively affected. Additionally, children who survive severe malaria may have cognitive impairment that affect their ability to learn. Even mild episodes can have a cumulative negative impact on learning. In sum, malaria has not only direct effects on public health through morbidity and mortality, but also important indirect effects that are less recognized but of similar importance. Eliminating malaria would therefore have a bigger impact on population health that can be anticipated just by looking at the direct burden. Malaria affects a country's economic prospects in both direct and indirect ways. Some of these effects may occur in the short term, while others may take decades to manifest. Countries that suffer a high rate of deaths due to malaria lose out from a reduction in their future workforce. In the short term, the working age population is less productive because of the time lost to being ill or caring for a sick family member. Malaria is an opportunity cost, diverting resources that could be used for other personal, family, and governmental priorities. In particular, families are at risk of impoverishment because of malaria, as it increases out-of-pocket spending on treatment while also reducing income if days at work are lost because of illness or caring for a family member. Malaria affects economies indirectly by discouraging companies' investment in their country. Malaria can also cause workers to be less productive due to impairment from severe or repeated malaria infections. A recent analysis using data from 180 countries found that a 10% reduction in malaria case incidence was associated with a nearly 0.3% increase in the level of per capita income over the period from 2000 to 2017. Assuming that the associations between the level of income and its determinants, including malaria incidence and other factors, remain constant over time, a 100% reduction of malaria case incidence or elimination of malaria would be associated with the average per capita income increase of nearly 3%. The economies of low-income countries and those with the highest incidence of malaria will benefit more from malaria elimination than will higher income and lower incidence countries. In the group of countries with the lowest income in 2017, malaria elimination would be associated with an increase in national per capita income of nearly 16%. Malaria does not affect everyone equally. On the global level, malaria affects resource-limited countries more than it affects wealthy countries. More than 90% of cases and deaths occur in sub-Saharan Africa. In resource-limited countries, persistent inequities mean that malaria affects some groups more than others. Let's discuss a few of the groups that are disadvantaged by malaria. In countries where malaria is highly endemic, children have the highest rates of mortality from the disease. More than 60% of deaths in the world are in children under the age of 5. Children are more severely affected by malaria compared to adults because their immune systems are immature and they are unlikely to have developed immunity to the infection. Pregnant women, particularly primigravida or pregnant for the first time, become more susceptible to malaria when they become pregnant, and the consequences of infection are more harmful to mother and fetus than to non-pregnant women. Pregnant women who are infected with malaria are more likely to die and more likely to develop syndromes like respiratory distress and cerebral malaria. We have already discussed the harmful consequences for their fetus and infants. People living with HIV/AIDS or other immunocompromising conditions are at increased risk of complications and deaths from malaria infection. HIV-infected individuals experience a greater frequency of severe malaria and an increased viral load following infection with Plasmodium falciparum. Finally, we know that poverty and poor housing increases exposure to the mosquitoes that transmit malaria. Additionally, in many places, poorer people have less access to health care and might have to pay more out of pocket to reach a health facility and receive services. Eliminating malaria reduces out-of-pocket expenditures, decreasing the risk of further impoverishment. Therefore, for these reasons, attacking malaria will help to reduce some of these inequities. These data show how quickly malaria can resurge after vector control is halted. These are all historical examples from Asia, Africa, the Americas, and Europe that were compiled in a systematic review of historical resurgence events. The y-axis shows a measure of malaria transmission, either parasite prevalence, number of malaria cases, or malaria incidence. The x-axis shows the years, and arrows indicate where a pilot program ended or control was relaxed. In all cases, malaria transmission increased within a few years. This review identified 75 resurgence events in the scientific literature, and nearly all were determined to be a result of the weakening of a malaria control program. This weakening was due to funding shortages, complacency, or disruptions caused by war or natural disasters. Technical issues such as insecticide resistance were secondary and less responsible for resurgences than operational issues. It is important to remember that as transmission declines towards zero over time, fewer and fewer people in the population are infected and population-level immunity begins to decline. As a result, a sudden increase in transmission can lead to a large number of people falling ill and potentially dying. These outbreaks or epidemics pose significant challenges to governments and politicians and may threaten industries such as tourism. The take-home message from this slide is that getting close to zero but failing to actually reach zero put countries at risk of rebounds. Later in this course, when we get to the section on prevention of re-establishment, we will talk about the flip side of this issue, which is that the countries that manage to eliminate malaria tend to stay at zero. So while falling short of elimination puts you at risk of rebounds, actually achieving elimination increases the likelihood of maintaining that state. Let's pause for a moment and consider the situation in your country with respect to malaria elimination. Why do you think malaria should be eliminated from your country? What would be the benefit to your country from eliminating? What kinds of argument for malaria elimination would be important to policymakers? What information do you think would be the most important to communities? Choose a rapporteur who will report back to the full group. In this module, we learned that the global malaria burden has declined substantially over the last 120 years, and there are now large regions of the world that are malaria-free, such as Europe, North America, and Australia. We also learned that there are many reasons to justify malaria elimination. Elimination removes malaria as a significant public health problem or even as a public health threat. It promotes economic growth and it decreases inequities. Finally, we also learned that countries that come close to elimination but then weaken their control efforts often experience significant resurgences in malaria transmission that can put a large number of people at risk of severe disease and death.